Imagine sitting in a medical school lecture, learning to diagnose skin conditions. However, slide after slide shows majority light skin tone models. Then every couple pictures are medium skin tones, but almost never dark skin tones. This is not just a mistake. A study by Louis and Wilkes analyzed over 4,000 images from widely used medical textbooks, Atlas of Human Anatomy, Bates Guide to Physical Examination and History Taking, Clinically Oriented Anatomy, and Gray's Anatomy for students. They found that out of the skin tones represented, 74.5% of medical textbook images showed light skin tones, 21% medium skin tones, and only 4.5% of dark skin tone images. Even when diverse racial representation exists in text, skin tone diversity is missing. They further explain, uneven representation in the curriculum has been identified as an important contributor to racial inequality in healthcare experience, treatment, and patient outcomes. This lack of representation has real-world consequences for patients with skin of color. Research by Croce and colleagues found that redness, known as erythema, can be much harder to detect on darker skin. Because standard scoring systems for skin conditions rely on visible redness as a measure of severity, they often underestimate how serious the disease is in these patients. When the assessments are adjusted for that bias, Black children are shown to have up to 6 times the risk of severe atopic dermatitis compared to white children. They also found that Black and Latinx children are 3 times more likely to experience persistent atopic dermatitis when compared to children with light-toned skin. Persistent atopic dermatitis is linked to increased atopic dermatitis severity, higher rates of asthma, greater atopic dermatitis burden, and worse overall health. The risk that misdiagnosis holds gets even higher when it involves skin cancer. Narla and colleagues report that non-Hispanic Black patients are often diagnosed with melanoma at later stages, leading to survival rates dropping. Specifically, the 5-year survival rate is 66% for non-Hispanic Black patients, compared with 90% for non-Hispanic white patients. This means Black patients are more likely to die from melanoma, largely because it is diagnosed later when treatment is less effective. These disparities have been directly connected to the training of healthcare workers. They found that melanin-rich skin is covered in only 13% of medical school curricula, and just 4% of those discussions focus on diagnosis and treatment. Ongoro and colleagues argue this educational gap contributes to delayed diagnosis for patients with skin of color, misdiagnosis of certain conditions, and inadequate treatment given. According to Genodia and colleagues in a 2025 study published by the Journal of the National Medical Association, 77.4% of residents reported low confidence in identifying dermatologic skin lesions, and 87.1% reported low confidence in treating basic conditions in people of color. This level of uncertainty shows just how serious the training gap is. When most educational visuals show light skin models, it improperly prepares the future doctors in what to think normal signs and symptoms are for common conditions. This deficiency means conditions on darker skin may be overlooked or misdiagnosed, not because the disease is different, but because they are not trained to recognize it. Some schools are working to improve these shortcomings. Perlman and colleagues explain how action committees have started to review lecture slides for skin of color content and provide alternative images where information is lacking. Also, tools like Visual TX are being used to give students an image bank that includes broad skin tone representation. Still, the authors stress that the lack of diversity in dermatology education is a persistent problem. Fixing this gap will include schools integrating diverse skin images into lectures, exams, and case-based learning. The responsibility is also on credentialing boards and licensing agencies, such as the American Board of Dermatology and hospital credentialing committees, to require proof of competence in diagnosing skin conditions in people with skin of color before granting certification and renewal. This would raise accuracy across all patient assessments and rebuild trust with patients who have skin of color. Funding agencies and journals can also play a role by requiring diverse patient representation in research, prioritizing grants for conditions that affect people with skin of color, and requiring research to include photographic evidence across multiple skin tones. This would create stronger data and lead to better care for communities that have been long overlooked in dermatology studies. Representation in dermatology is not just about diversity in images, it is about preserving lives. Through changing the way healthcare providers are taught, tested, and what we require from doctors, this will ensure that every patient with any skin tone is seen, diagnosed, and treated with the same accuracy and urgency.